notes, or you have anything else?
No, that's all right.
Okay.
Oh, I just don't do, oh, you can just do down click. Good morning. How's everybody today?
Very well, how are you?
Very good.
Good.
I got one response, so that's good. I guess everyone else is still waking up. I'm very, very pleased and honored to be teaching in the Maternal Fetal Medicine Fellowship Seminar Series. And I'm glad Dr. Scheigen made it today because she figures really prominently in the presentation. Anyway.
Not one of those what not to do, is it?
No. Anyway, I'm going to be talking today on statistics and perinatal research. For those of you who don't know, I'm the epidemiologist biostatistician here in the department. I absolutely love statistics, which kind of like sets me apart from most people, but that's why I'm here, I guess. Anyway, what we'll be doing today is talking a lot about specific research questions, types of data, and then the statistical tests used to answer those questions. We'll be using a lot of examples, and be forewarned, the maternal fetal medicine faculty and the fellows feature prominently in the examples. All right, why are statistics important? Well, statistics may be used to assess risk and protective factors in the etiology of disease. This is something that I love because I have a whodunit mentality and I love doing analyses like this. The efficacy of different treatments, which probably really matter to you as clinicians, or you can also use statistics to develop a predictive model of disease outcome, something I also love to do. The choice of a statistical test will basically depend on two things. One, characteristics of the data, and two, the research questions to be answered. An understanding of statistical procedures and their applications is essential to critically evaluate the medical literature. Now, all of you as clinicians, I'm sure, try to keep as up to date as possible in the latest findings in the literature, but yet you have to understand if the study was appropriately done, because the choice of statistics follows from the study design, and if you don't use the appropriate statistics and interpret them correctly, how can you ever tell if something is good science, which perhaps could be applied to your clinical practice? All right, types of data. Scales of measurement, there's basically 4 kinds of data. Data is usually classified as categorical, that is nominal or ordinal, or continuous, interval, or ratio. Nominal data has no rank or order or mathematical relationship to each other. They're just simply categories, groups. Examples could be eye color, race, sex, ABO blood group. Ordinal data has rank and order, but the differences between categories are not necessarily equal. Examples could be grades, academic ranks, socioeconomic classes, or year of MFM fellowship. Interval data has rank and order, and equal differences reflect equal amounts of the property being measured. It does not have an absolute 0 point, thus 0 does not equal the absence of the attribute. They can be added or subtracted, but not multiplied or divided. Examples are Fahrenheit and Celsius temperature scales. Now, fortunately, you have virtually no continuous data that's interval except for really these 2 temperature scales. But just to illustrate, say like if you have a difference of like 50 degrees and 40 degrees, 90 degrees or 100 degrees, you have a difference of 10 degrees in each of those 2 situations. But when it's 100 degrees out, you can't say that it's twice as hot as when it's 50 degrees out. And 0 does not mean the absence of heat or temperature. But fortunately, you will very rarely use interval data. Virtually.
Things like gravity and parity, where you can't have 1.5 pregnancies.
Oh, no, well, actually, if you have 0, that means you have zero parity. So, I mean, zero does mean zero in that situation. Parity would be a ratio data variable, which is the last one. And, pardon me? Age is also continuous. I mean, age is also ratio. If you're 50 years old, you're twice as old as someone who's 25. And you have a 25-year difference between 50 and 25. If you have an age of 0, you're not born yet.
Isn't it twice as hot if it's 100 and not 50?
That's my question.
No, I don't think so.
It's not. Because of the
Right.
temperature is an average of the kinetic of the amount of smoothing. And then whatever the rate is, we have to be the amount of
Twice as bad.
Anyway, 99% of the time, the continuous data that we use in your research is going to be ratio data. It has rank and order. Equal differences reflect equal amounts of the property being measured. It has an absolute 0 point, which indicates absence of the attributes. May be added, subtracted, multiplied, or divided. So really, height, weight, body mass index, blood glucose levels, serum cholesterol levels, gestational age of delivery, cervical length, virtually every continuous variable that you use will be ratio data. All right, time for some examples of statistical tests. I want to make this talk interaction, so can I have volunteers to read these 7 examples? Dr. Gross, could you please read the first one, and feel free to substitute Red Sox for Cardinals.
Yes, sir. Did the Red Sox and Cubs differ significantly from each other during the 2011, 12, 13 seasons
Wait a minute.
in terms of singles, doubles, triples, and home runs?
Wait a minute. I changed that to 2013.
No, you didn't.
I certainly, we might, hang on just a second.
Well, it really doesn't matter because they're
Oh.
better every year.
Suwan, could you,
Yes, I got it.
sorry, what a meathead. I apologize. I'm going with my computer. A lot of the things are similar, but I lost the
Whatever
effect.
year you pick, you're going to be
I lost the effect of this year.
It really doesn't matter. They're always better.
Go to the third one.
Let me
All
do
right,
this. I
it's
got-
the one for,
Trust me,
oh
it's
yeah,
this
it's the first one here. On my computer, it's the second. All right, now we're rolling. Perfect. Perfect. All right, see, Dr. Gross, 2013 Red Sox. They're actually going to change a lot this year without Jacoby Ellsbury. But anyway, could I have a volunteer to read the second one?
I can do it. Do MFM fellows at St. Louis University School of Medicine and WashU differ significantly from each other in terms of IQ?
And what is your hypothesis, Suwan?
They differ significantly in terms of IQ.
With, of course, the SLU fellows favored, right? All right, who would like to read the third one?
What is the strength of the association between hours of night call per week and systolic blood pressure? Correlation.
All right, Dr. Ramon, could you please read your own personalized example?
What is the average increase in annual income following completion of an MFM? Each hour spent under the education of the fellowship.
Under the tutelage of Dr. Ramon. All right, very good. Could I have?
I'm sure that's not like a logarithm.
Well, yeah, it's probably definitely exponential, where it's, you know, you kind of like pass the national debt
Right.
after about 100 hours or so. All right,
Step function.
all right. Could someone read the fifth example, please?
Endometrioid grade 3 endometrial cancer patients have higher 5-year survival than papillary serous clear cell endometrial cancer patients.
Mm-hmm.
Survival.
And can I have a volunteer for the sixth one, please? Going once, going twice.
Which demographic medical-surgical hysterectomy and health characteristics are significant and independent predictors of gestation and diabetes?
Mm-hmm. And could someone read the last one, please?
Which maternal and fetal in utero and postpartum factors are significant independent predictors of future obesity in the offspring through 20 years of age, not progression.
Thank you very much, everyone. you see we have a particular research question in mind, which is really driving the study, and the statistical test listed tells you how to get the answer to your study that you need. All right. What is the average workload per week of you MFM fellows? Gary, Katie, Suwan, or legally you're not supposed to work more than 80 hours a week, or do you work like 90, 100, 120? What would you say an average workload for you per week is?
50, 60 hours.
Okay. Anyway, the MFM faculty have noticed that sometimes you fellows feel downright pooped at the end of the week, and so they decided to do something about it. And so Dr. Ramon, in particular, and Dr. Scheiken, after hours in their laboratories, are developing these secret potions to have you fellows be more energetic. And Dr. Scheiken has come up with Scheiken's sensational stimulant. Dr. Ramon has come up with Ramon's amazing antidote. And they performed a clinical trial on you fellows. They had 45 fellows in each group. We have assume that we have a huge program in fellows, not just 3. Anyway, at the end of 2 weeks, the fellows reported how they felt. Did they feel much more energetic, somewhat more energetic, or no change? Now, if you just look going across the table, in the much more energetic column, which group has the higher percentage? All right, in the somewhat more energetic column, which group has the higher percentage? All right, Dr. Ramon, 44.4% of his fellows really didn't report any change, so the overall effect is what? Here is the chi-squared. It's significant, which means what?
More stimulating.
All right, there is a significant difference in energy level between the 2 groups, and apparently fellows taking Scheiken's sensational stimulant are more energetic than Ramon's amazing antidote. Now, all of you, I'm sure, have seen chi-squared innumerable times in the literature. Do any of you really know what it means or how it's calculated? Well, chi-squared is simply calculated through the use of observed and expected cell frequencies. And the way you calculate expected cell frequencies is, all right, if you take this cell here, the observed cell frequency is 15. The expected cell frequency is just simply the row total, 45, multiplied by the column total, 27, divided by the grand total, 90. And that yields an expected cell frequency there of 13.5. Similarly, this cell of 21, the expected cell frequency would be 45 times 34 divided by 90, which would give you 17. So if you do this for all 6 cells, and then look for each cell, the observed minus expected cell frequency, square that difference, divided by the expected cell frequency of the cell, add them up over all the cells, then you get your chi-squared value, 6.402 degrees of freedom, p less than 0.05. Very, very simple to calculate a chi-squared.
Why do you expect them to be different?
Pardon me?
Why do you expect them to be different?
Well, the expected cell frequencies, Dr. Martin, are just simply calculated based on your marginal totals. Just in terms of how the data shakes out here in the study, this is what you observe, but yet you calculate what you would expect, and what you observed and what you expect could be similar, but they're not generally identical. And you just want to see how much your obtained statistic, your obtained results, depart from what you would expect. And if that's occurring at 5% of the time or less, then you would say what you obtained actually is not really a high probability from what you would expect. And then you would say there is a significant difference.
I guess the way I think about it is what you observe is compared to a placebo or nothing.
Oh. Well, you don't really have.
Right, you don't have it in this case, but that's, well, I don't.
Are others kind of like confused in terms of how you calculate a chi-squared?
I guess I understand the calculation, I just don't.
understanding the concept.
To me why, if you're basing the expected based on actually what you observe, then the two are related.
Right. The two are related because the way you calculate the expected is really based on how many you observe in each group and how many are actually in this column here for this particular cell.
So you're relating it to the other one, really. You're relating it to the difference between the two groups expected.
Well, actually, both.
You're doing a proportion of the totals.
Right. Based on the column and row totals and the grand total, you have a certain expected frequency for each of the 6 cells. And then based on what those expected frequencies are and how different they are from the observed frequencies, that will tell you whether or not your chi-squared is significant or not. All right. Another categorical data test that is very familiar to all of you, I'm sure, is Fisher's exact test. This is used in 2x2 tables where 25% or more of the expected cell frequencies are less than 5. Now suppose if we continue with our example, the much more energetic column and somewhat more energetic column were grouped in terms of you just feel more energetic, yes or no, and then compared with no change. And then instead of 45 in each group, suppose we just took a random sample of 15 fellows from each group, and then we have a 2x2 table with these observed cell frequencies. In parentheses, we have the expected cell frequencies. Are any of these expected cell frequencies less than 5? All right, 2 of them are, so we would use Fisher's exact test. The p-value is 0.43, which indicates what? Right. And this is in contrast to the first example that actually favored Dr. Scheichen's group. All right. Another categorical data statistical test is called kappa. If any of you have ever worked with kappa or heard of kappa? Dr. Ramon has. The kappa statistic is an index of agreement, and you can use it to measure inter-observer agreement at 2 readings or inter-observer agreement at a single reading. It estimates the proportion of observed agreement beyond what would be expected to occur by chance. The range of kappa is 0 to 1, where 1 is perfect agreement and 0 is agreement no better than chance. So actually the baseline level here for kappa 0, you have some agreement, but you would always expect some agreement to occur by chance. Kappa tells you, do you have agreement beyond what you would expect by chance? All right, here's another example involving the fellows. Let's just choose Gary and Suan. Suppose that after 2 years in the program, Gary and Suan got together just to evaluate the curriculum, and in particular, they wanted to evaluate the value or the efficacy of these Wednesday morning lectures. So they considered all 78 MFM fellowship lectures during 2 years, 2 successive years, and then Gary and Suan just said, what do you think of this lecture? What do you think of this lecture? Was this helpful to our training? Did this increase our knowledge base? Is this something we could use in our clinical practice? And they just said, this lecture is helpful, this lecture is not helpful. Of the 78 lectures, Gary and Suan agreed that 62 were helpful. They also agreed that 6 weren't really helpful. Now the 2 discordant cells are here, where Suan thought 4 lectures were helpful. Gary said, forget it. And then here, Gary actually thought 6 lectures were helpful, and Suan said, no, I don't really think so. So now, if you want to calculate an index of agreement based on this data, you work with 2 things. You work with your observed level of agreement and your expected level of agreement. The expected level agreement, again, just calculated as we have before. For this cell, the row total 66 times 68 divided by 78 gives you an expected agreement for this cell of 57.5 lectures. Similarly, for this cell of agreement, 12 times 10 divided by 78, 1.5. So your expected level of agreement then is 57.5 plus 1.5 divided by 78 gives you 0.76. Now, your observed agreement was actually higher than this. You have 62 plus 6, that's 68 out of 78. Your observed level of agreement was thus 68 over 78.87. How do you calculate kappa? You just take the observed agreement minus the expected agreement over 1 minus the expected agreement, because again, you want to know how much is your agreement above what you would expect by chance. So this calculates to a kappa of 0.46. What does a kappa of 0.46 mean? Well, if you have a kappa of 1, that indicates absolutely perfect agreement, which never occurs in research. A kappa of 0.81 to 0.99, that's almost perfect agreement, which very rarely occurs in research. 0.61 to 0.80 strong agreement, 0.41 to 0.60 moderate agreement. The other categories are listed here. So if you have a kappa of 0.46, that indicates what? That indicates that Gary and Suwan show moderate agreement above what would be expected to occur by chance on the helpfulness of MFM fellowship lectures. Did all of you follow that example?
Now for this one, the expected agreement, how do you figure that?
Oh, same as before.
Okay, same thing. Okay.
Yeah, so you take the row total 66 times the column total 68 divided by the grand total 78, and then that gets you 57.5 expected lectures where both fellows agreed for that particular cell. Did everybody follow the kappa example? All right, let's switch to continuous data. The most popular univariate statistical test for continuous data for 2 independent samples is the independent student's t-test. Has anyone not heard of a t-test? All right. What a t-test does, it essentially compares the means of 2 samples from populations assumed to be normally distributed. If the normality assumption is violated, you have to use a non-parametric test. Non-parametric is equivalent to not normally distributed, and you have specialized statistical tests particularly useful, or that should be used when the data is not normally distributed. In this case, you would use something like the Kolmogorov-Smirnov test, Mann-Whitney-U test, but if the data is normally distributed and it's continuous, then you would use a t-test for 2 independent samples. You really need just 3 things to calculate an independent student's t-test. You need to have the sample sizes, difference in sample means, and the variability of the samples. All right. Remember the earlier example of Dr. Scheiken's sensational stimulant caused the fellows to be more energetic. What could be an explanation for that? Well, Dr. Scheiken was pinned down, and she confessed that one of her secret ingredients in her sensational stimulant was a high iron content. So this could raise hemoglobin levels and make the fellows more energetic. Suppose that the post-treatment mean hemoglobin levels, sample sizes, and variability of the sampling distribution of the difference in sample means were as follows. The mean post-treatment hemoglobin level for Dr. Scheiken's sensational stimulant was 13.4 grams per deciliter. That for Dr. Ramon's group was 12.4 grams per deciliter. You still have a sample size of 45 in each group. The standard error of the sampling distribution of the difference in sample means is 0.24. Does everyone understand what this means, the standard error of the sampling distribution? Dr. Martin is nodding. All of you understand? Basically, in a nutshell, you have a sampling distribution of your desired statistic, which is your difference in sample means. You want to know where on the sampling distribution of difference in sample means your observed sample falls, and if it would be a rare occurrence or a common occurrence. Your t-statistic, which you use to calculate this, you take your observed difference in mean hemoglobin levels, which gives you a difference of 1 favoring Dr. Scheiken's group minus the expected difference in sample means under the null hypothesis, which is 0 if you assume that there is no difference between groups, divided by the standard error of the sampling distribution of the difference in sample means 0.24. This gives you a t-statistic of 4.17, 88 degrees of freedom, p less than 0.0001. Now remember, generally the rule of thumb in statistics is you would reject the null hypothesis of no difference between groups if your obtained result would occur 5% of the time or less. Now 5% of the time or less, it could happen when there is no difference, but we're saying if it's only going to occur 1 in 20 times, we'll be willing to take that risk. It's called a type 1 error, and reject the null hypothesis and say there's evidence of a true difference. Well, is this less than 5%? All right, this is actually less than 1/100th of 1%. So really, if there was no difference in hemoglobin levels between the two groups, this would be a really rare occurrence. So this provides evidence for what? This p-value would tell you what? If you're comparing the mean hemoglobin levels between Dr. Scheiken's group and Dr. Ramon's group, and you obtain a p-value of less than 0.0001, that tells you what?
There's less than 1/100% chance that the hemoglobin levels are 6%.
Right. So this provides strong evidence that there really is a difference in post-treatment hemoglobin levels between Dr. Scheiken's group and Dr. Ramon's group. So you reject the null hypothesis of no difference and say from this result, we have strong evidence that Dr. Scheiken's group does have significantly higher hemoglobin levels than Dr. Ramon's group. Yes, Dr. Ramon?
Question about using standard deviation.
Uh-huh.
What's the standard error?
All right. A good way to think about that, suppose that you just have 45 post-treatment hemoglobin levels, and you just want to look at the variability of those 45 hemoglobin levels. That would be given by the standard deviation. But now the standard error would be the variability of the sampling distribution of your sample statistic, which in this case is the difference in sample means. The best way to think about this is, suppose that you had an infinite number of fellows that took Dr. Scheiken's potion and an infinite number of fellows that took Dr. Ramon's potion. And then you took 45 fellows from each group. You calculate the mean hemoglobin level from each group. You take the difference in the two sample mean hemoglobin levels, Dr. Scheiken minus Dr. Ramon, get that result, put the 45 fellows back in their respective groups, take out another 45 fellows from both groups, calculate the sample means for each group again, take the difference for those two samples, Dr. Scheiken minus Dr. Ramon, put the fellows back in their respective groups again, take out another 45 fellows from each group, do this an infinite number of times, and then plot all those differences in sample means on a distribution. The variability of that sampling distribution of the difference in sample means is your standard error. Now, if under the null hypothesis there is no difference between Dr. Scheiken's group and Dr. Ramon's group, what would the central tendency or the mean of that sampling distribution of the difference in sample means be? It would be 0. Now, some sample differences would favor Dr. Scheiken's group, some would favor Dr. Ramon's group, but really if there is no difference in mean hemoglobin levels between groups, the central tendency or mean of that distribution of the difference in sample means would be 0. You want to know where on that distribution of the difference in sample means your obtained difference, which in this case is a difference of 1, falls in that distribution. Did that make things clearer?
Yeah, but it seems like that's just theoretical to the infinite number of times.
Right.
As opposed to standard deviation, which is the actual observed deviation of that sample.
Right. Right. Well, but still, you base your theoretical distribution on what you already know, which is the variability of your individual samples, And then if you take the difference in sample means and create a different distribution, you have another variability for that distribution. So granted, in determining your standard error, it is based on a theoretical distribution of an infinite number of differences in sample means, but you can still calculate what that variability should be from your data here and the variability of your samples. You're kind of like, sort of like, well, maybe, but let me think about it some more. All right, I mean, did everyone sort of follow the example? Does anybody have any more questions, comments, clarifications, as my biology teacher in high school used to say?
Degrees of freedom?
Sure. Degrees of freedom are just simply calculated by like the number of groups minus 1 for each group in a t-test. So here, if you have 45 per group, 45 minus 1 for 2 groups, you actually have a total of 88 degrees of freedom. Anybody have any other questions? This is kind of like a general sense of how you calculate a t-test and the theoretical thinking that really goes into how it's calculated. Did everyone sort of follow the example? All right.
So the degrees of freedom is how much wiggle room do you have in essence for these different cells to be filled in.
Right.
So as you go down, once you fill up all your cells, if you have a certain total, and once all of your cells besides one are filled out, that last one has to be the difference from everything else from your total. So that's why so that last cell, at least in this situation, doesn't have any wiggle room, because it has to be
right.
whatever's missing. So that's why you have the degrees of freedom is total n value minus 1.
So the degrees of freedom goes up in your sample size.
Correct.
Right.
And is a bigger degree of freedom, is that better, a stronger? Like I'm just trying to understand.
Well, not necessarily. Well,
what does that mean in terms of believing or not believing these the results?
Well, generally in statistics, a larger sample size for any research question results in more precise estimates. So really, the larger your sample size, the more assurance you have that what you obtained is really true and accurate and valid. But there is no rule of thumb that says, 90 degrees of freedom is better than 80 degrees of freedom or anything like that. Just as Gary pointed out, it's kind of like the variability or the room that your data has to wiggle after certain other conditions are set. The t-distribution is actually calculated based on certain degrees of freedom, so you would actually have a different t-value, say like for 80 degrees of freedom or 100 degrees of freedom, but this is what it would be and the proportion of the p-value at 88 degrees of freedom.
In papers, they don't usually give.
Well, actually,
they don't. Like they don't.
They don't tell you all the statistical. They just say this is what we use.
Right. All right. Let's move on to correlation. Has everyone heard of correlation? All right. Correlation coefficient measures the strength of the association between two variables. It's denoted by R. The range is from -1 to +1, depending on the strength of the association and whether a positive change in one variable produces a positive or negative change in the other variable. A guide to interpreting the strength of the correlation coefficient, if you're working with absolute values, is that if you have a correlation from 0 to 1, that's a strong correlation. 0.5 to 0.79 moderate, 0.2 to 0.49 weak, 0 to 0.19 negligible. All right, here's another plot involving MFM fellows, and Suwan really figures prominently here because it seems like when I see him, he's always stayed up all night. Where's Suwan?
He got caught in the labor flood.
Oh, he's not even here. All right. Anyway, I gave you the correlation coefficient here, but if you can possibly ignore it and then just look at the data, what does the data tell you? As hours of night call increase, what generally happens to systolic blood pressure? As hours of night call increase, generally what happens to systolic blood pressure? Does it increase or decrease? Increases. So you have a positive relationship, a positive correlation. our 0.73 indicates a moderately strong correlation between the two variables. All right, suppose we wanted to quantify this now and fit a regression line to it. That's given here, where systolic blood pressure equals this plus this times this. This is your y-intercept, this is your slope. Generally then, for each hour increase in night call, the systolic blood pressure would increase by how much? 0.38 millimeters Hg. If you had 0 night call, the fellows start with a baseline systolic blood pressure of about 126, and if they actually had 50 hours of night call, based on this data, they would have on average a systolic blood pressure of 146, approximately. Did everybody follow that? All right, whoops. All right, let's talk about receiver operating characteristic curve analysis. Has anyone here heard of ROC curves? I love ROC curves because they are so clinically useful. And basically, what an ROC curve does is it determines the efficacy of, say, using one variable, a combination of variables, a model, a risk score on discriminating between patients who have the endpoint and patients who don't have the endpoint in question. And what you as clinicians do, why an ROC curve is so useful, is that you can use it to set certain cutoff points to determine sensitivity and specificity. Because in your clinical practice, it might be more efficacious to identify as many patients as possible that have the outcome, that then you would like maximize your sensitivity, or perhaps you would say, well, I'd like to identify maybe a good portion of these having the endpoint, but I don't have to identify all of them. I don't want to increase sensitivity at the expense of specificity, because if you decrease your specificity, you have a lot of false positives, and you might not want that either. But you as clinicians, for each particular outcome, have to determine what is the optimal cut point to use, taken from this ROC curve, to use in my clinical practice to differentiate patients who have the outcome in question from patients that don't. All right. The ROC curve uses sensitivity and specificity, and I'm sure these are familiar terms with you just from screening training. Sensitivity and specificity measure the ability of a screening test to discriminate between persons who have the disease and persons who do not have the disease. These probabilities are determined by comparing the results of the screening test with those derived by some definitive diagnostic procedure. Sensitivity, again, for review, because I'm sure these are familiar terms to you. Sensitivity is the ability of the screening test to be positive when the person tested truly has the disease. A positive screening test, however, may be obtained for persons that do not have the disease. These persons are known as false positives. Specificity, on the other hand, is the ability of the screening test to be negative when the person tested truly does not have the disease. A negative screening test may be obtained for persons who have the disease. These persons are known as false negatives. All right, here's an example of an ROC curve. This was work that I did for Dr. Blaskowitz, Dr. Schwartz, and Dr. Scolari in a retained placenta study where we wanted to know the relationship between length of the third stage of labor. These are actually infants very, very premature, born less than or equal to 27 weeks gestation. We wanted to know the relationship of length of the third stage of labor for predicting a composite endpoint. And the composite endpoint consisted of manual removal of the placenta, dilation and curettage removal of the placenta, chorioamnionitis, or endometritis. So if a woman had any of these endpoints, she was included in the composite outcome. And the length of the third stage of labor is plotted here, and the relationship between sensitivity and 1 minus specificity is given. And as you can see, well, first of all, if you had absolutely perfect discriminatory power in your variable, your ROC curve would extend up to your upper left-hand corner and across, because this would indicate 100% sensitivity. This would also indicate 100% specificity. This never occurs in clinical practice or research. What you want to do is optimize the curve to be as high as possible above the 45-degree line, which indicates simply chance probability. Anyway, the area under the curve was still very significant, 82.3%, p less than 0.001. So you have good discriminatory power, actually excellent discriminatory power between women with the outcome and women without the outcome based on length of the third stage of labor. Now, you as clinicians have to decide what would be a good cutoff to use in clinical practice to identify women with the composite endpoint and women who don't have the composite endpoint. All right, if you take 30 minutes here as your cutoff and just say, I want to use this as a cutoff in my clinical practice because women that are above 30 minutes, I can identify a certain sensitivity. So many women that have the composite endpoint will have lengths of third stage of labor more than 30 minutes. And then conversely, of the women who don't have the composite endpoint, that percentage, how many are below 30 minutes? Well, from the ROC curve, if you use this as your cutoff, you have a sensitivity of 70%, which tells you that 70% of the women in this study who have the composite endpoint have lengths of third stage of labor more than 30 minutes. And the specificity, this is 1 minus specificity, so this is approximately 78% of women who do not have the composite endpoint have lengths of third stage of labor below 30 minutes. All right, so if you use that as a cutoff, sensitivity 70% above, 78% below, that's fairly good. But now supposing that you as clinicians said 78 specificity really isn't that good, I'd like to try to increase my specificity. So if you take 60 minutes as your cutoff, what happens? Well, your sensitivity now decreases to 61%. 61% of women who have the composite endpoint will have lengths of third stage of labor more than 60 minutes. Your specificity increases to like 93%, which is excellent. And then as you notice, as the length of third stage of labor continues to increase, 90 minutes, 120, 150, what you essentially have is that your specificity really stays approximately constant between like 92 to 94%, while your sensitivity plummets. So probably the optimal cutoff to use would lie somewhere between 30 minutes and 60 minutes. Because if you use a cutoff in your clinical practice somewhere in here, you would probably identify about 2/3 of the women that have the composite endpoint as being above this cutoff, and then you would still probably have a specificity of about maybe 88% that are below that cutoff. Did everybody see and understand how an ROC curve could be used for cutoffs that you could be using in your clinical practice? All right, now we come to survival analysis. If I had to choose one type of analysis that's my favorite, that I absolutely revel in, it's probably survival analysis. Because my dissertation in Pittsburgh looked at the intrafamilial risk of insulin-dependent diabetes, now known as type 1 diabetes, among siblings of index cases. I did a lot of survival analysis through various ages in Pittsburgh. Survival analysis is employed whenever risk over time is to be determined and subjects are followed for varying lengths of observation. The end point could be diagnosis of disease, development of disease complication, mortality, or really any outcome that you'd like. The important thing about survival analysis, the really keynote aspect of survival analysis, is that it adjusts for differential length of follow-up. All subjects need not have been followed for the entire period of desired observation in order to be utilized in the survival risk estimates. Each subject contributes to the estimates according to their period of observation. For all of you who come to Journal Club, you know that we have a lot of articles that deal with survival analysis. Right, the time variable in survival analysis may be age, as I just mentioned in my work in Pittsburgh, time from disease diagnosis or initiation of treatment or completion of surgery, or any other unit of follow-up. The cumulative survival estimates may be compared simultaneously across all levels of a variable or between paired levels of a variable. All right, let's look at some examples. Regretfully, this is not an MFM example, but tough. You'll have to bear with me. All right, for all of you old-timers here, maybe I shouldn't have used that word. Actually, there's probably only one person that would remember him in the room. Good old Dr. Ramon, you remember Chris Chung, right? All right, this is from Chris Chung's resident research project, and he looked at factors that impact cumulative 5-year survival rates in endometrioid cancer patients. One of the first things we looked at was race. Now you notice that these survival curves, they're comparing white and non-white groups, but really the non-white group only had one Asian woman in it, so it's essentially a black-white comparison. And these survival curves indicate the great importance of when you're doing survival analysis, you have to understand the entire survival risk pattern, not just where they end up or the final result. Because black and white women, the cumulative 5-year result was virtually the same. About 72, 73% that was their cumulative 5-year survival. But the way the groups got there was completely different. Who can describe these survival patterns for the white group and the black group? Yeah, if you had to describe the white group survival, what would you say? Kind of like a gradual, steady decline over time over the 5-year observation period. All right, what about the black group? Right. The black group essentially falls off a cliff during their first year and a half, and then their survival levels off. Can anyone venture a reason, a speculation, why you would see these survival patterns in black and white endometrioid cancer patients? I should point out, these survival estimates are not taken from the time of diagnosis. They're taken from the time that they are first seen at St. Mary's Hospital, which might help in speculation. Sorry, Dr. Ramon, what? Right, so the patients are reported to St. Mary's Hospital at different stages, and probably the black group reports in later stages of disease. That would be like a perfect explanation. For whatever reason, the black patients come here when their disease is more advanced, and thus their prognosis is poorer. And that was borne out in the next survival slide. We're actually comparing the tumor grades in terms of 5-year survival, and generally the thinking is that the more poorly differentiated your tumor is, the worse your prognosis is for survival. So here you have well-differentiated, biologically differentiated, poorly differentiated tumors, grades 1, 2, and 3. The cumulative 5-year survival for well-differentiated tumors is about 95%. These women actually survive very well. If you actually have a grade 2 tumor, your cumulative 5-year survival drops down to about 72%. And if you have a poorly differentiated as grade 3 tumor, less than 50% of these women make it to 5 years. Now remember, one of our earlier research questions that we asked was, what about papillary serous clear cell? What is their survival like, particularly in relation to the grade 3 endometrioid tumors? This was actually Nikki Dubas's resident research project. And when you add her survival curve in here, again, if you're looking at the survival estimates simultaneously across all 4 groups, differences are highly significant. But yet when you're comparing the grade 3 to the papillary serous clear cell, this pairwise comparison was not significant. Now, if there really is no difference in cumulative 5-year survival between the 2 groups, perhaps that could impact your patient care, patient management decisions. But yet, one note of caution, Nikki only had 25 women in her papillary serous clear cell group. This cancer just occurs very, very infrequently particularly in comparison to the endometrioid cancer. So I would feel a little better if the sample size for this was a little higher, then compare the two survival curves and see if they're different. But from right now, from what we have, the data shows that they're not.
But the two aren't really related,
Right?
because if it was strictly a difference between blacks and whites
Mm-hmm.
in histology, then that 5-year survival shouldn't have ended up at the same place.
Well,
They should have
no.
all, because,
You're
there's a
saying,
difference between stage and disease
right?
and underlying disease.
Mm-hmm.
And if they all ended up with the same, if both groups had the same 5-year
5-year.
survival rate,
Mm-hmm.
and the survival rate depends upon grade, then the grades must have been similar. Otherwise, their 5-year survival, their overall 5-year survival rates should have been different.
So,
And they weren't.
so you're saying not only, right, if the blacks say had, if they came at later stages of disease, but yet they still ended up the same place as whites,
And the overall
after 5
distribution
years.
of grade must have been the same. Just they presented later, at a later course of the same, at a later point in the same illness.
Well, I mean, during the course of disease, can your tumor grade change?
Well, I don't know the answer to that. But look how many are alive.
Mm-hmm.
And if you go back to that very first slide,
Which one?
that one.
This guy?
Right.
Mm-hmm.
So if a higher percentage of the white women had
Mhm.
had a lower, significantly lower grade of tumor,
Mm-hmm.
then wouldn't have you expected more than a 3% difference in 5-year survival? Given that 5-year survival for the women with the well-differentiated cancer looks like it's about 90%.
Actually, one note of caution. This actually definitely compares the two race groups.
Right.
But this does not take race into account. This just takes the entire sample into account. What we actually did not do is actually do this individually for the black patients and then for the white patients and to see if the risk patterns were different. But if the tumor grades were different for each race, then obviously that would impact survival.
But I think that curve
Mm-hmm.
doesn't illustrate difference in grade of tumor.
Oh, no,
between
not
the
at all.
two groups.
No,
Okay.
this is just simply the race pattern, but it doesn't take anything else into account.
And given
and-
the similar 5-year survival, it suggests that in fact their illnesses were very similar.
All right, but then what accounts for the great early mortality then in blacks if they essentially have the same level of severity of disease?
Well, potentially they had their primary hysterectomy somewhere else,
Mm-hmm.
and then they didn't show up for follow-up,
Okay,
and they came back to St. Mary's, and when they came back, 3 years later with disseminated disease,
right,
the person who did their primary hyst said, no way can I take care of you now, you need the big hospital.
see a problem here is
Whereas
that,
the woman who had cancer diagnosed at an outlying hospital might have said, you know what, I want to go to a tertiary care center, I want to go see an actual GYN oncologist,
right,
and had some of those early recurrences palliated,
right.
which allowed her to survive longer
Right.
with her disease.
See, a problem with this is that we don't really know when the disease was diagnosed. All we know is that this is from when they first presented at St. Mary's. But they could have had disease for who knows how long before they came to St. Mary's. Very good. Thank you, Dr. Martin. Anyone else have any comments or questions? All right, this is the last batch of statistics that we'll talk about today. And this is multivariate analysis, multiple logistic regression, and Cox regression. Are these terms familiar with all of you? sort of. Right. These are very, very common in the literature. They're also very common in the journal club articles we've been discussing. Multiple logistic regression, I love this technique because, again, we're talking about predictive models here. I love developing models to predict things. All right, multiple logistic regression develops a predictive model of a dependent variable from multiple independent variables. The dependent variable is dichotomous. Here is something which sets it apart from survival analysis. Duration of follow-up is not a concern in multiple logistic regression. The intent is only if the subject developed the outcome in question, yes or no. That's your dependent variable. We don't really care how long it took them to get to it. While the model is usually one of etiology or causation of risk and protective factors of the dependent variable, the model also may be one of identification or association of variables with the dependent variable. Each variable in the model is adjusted for the possible confounding influence of all other variables in the model. This is very, very important because a variable might be significantly related to the outcome in and of itself, but when you take other factors into account, such as age, race, socioeconomic status, prior history of whatever, then the variable might not have a significant relationship. Cox regression, I always like teaching that it can be viewed as a multiple logistic regression superimposed over a life table framework. Significant independent variables are developed in a predictive model for a dichotomous dependent variable over time. The model adjusts for differential length of follow-up. All right, a couple more examples. This is one of my all-time favorite resident research projects. It's urinary incontinence. It's fecal incontinence in women with urinary incontinence. I've always held the position that you can't get excited about fecal incontinence and urinary incontinence. You can't get excited about anything. I actually put this in my Christmas letter several years ago to let all my family and friends know that there's never a dull moment here in obstetrics, gynecology, and women's health.
I want to get on that mailing list.
Anyway, this was done by Laura Parks. I'm sure Dr. Ramon remembers Laura Parks. She's now at WashU, which really isn't such a stigma because half of us came from WashU, including me.
IQ lowered.
Right, that's right. Keep that in perspective.
We will not hold that against us.
Right. Anyway, Laura did this project in tandem with good old Dr. Steele, and what they set out to do was that, and you can comment on this just with your patients and how you feel. Urinary incontinence doesn't really carry the same stigma that it used to carry, probably because so many people nowadays have urinary incontinence. You see all these Depends commercials on TV and other things. So you're kind of like losing the stigma for that. But on the other hand, fecal incontinence is very much a verboten subject still. People are really embarrassed to talk about that. I mean, have any of you, this might not be an MFM deal, but yet you're still all physicians. Does fecal incontinence ever come up in your clinical practice? Rarely?
Fortunately, rarely.
Okay. All right. Anyway.
Nothing scares me anymore. So
okay.
If it happens maybe once a year.
All right. Anyway, what Laura and Dr. Steele wanted to do is, if you had fecal incontinence that was undisclosed in women who were reporting for a primary complaint of urinary incontinence, they wanted to know, first of all, how many of these women with urinary incontinence had unreported fecal incontinence, and second, what factors or variables were associated with unreported fecal incontinence in women reporting for a primary complaint of urinary incontinence. Because if the physician noticed the person having these factors, they could say, Mrs. Jones, I know that you're here because you have problems with your urination, but do you also have problems with your defecation? Do you have problems with fecal incontinence? And this could open up another whole avenue of discussion to identify and then treat a condition which probably wouldn't have been reported. So that was the purpose why the study was done. And actually, these 4 variables were found to be univariately associated with unreported fecal incontinence in women with urinary incontinence. And then they were all put into a multiple logistic regression model. Do you have fecal incontinence? And you see all of the variables here had elevated odds ratios, which indicate, a greater risk of having fecal incontinence. But yet, of these 4 variables, what are the 2 really hallmark conditions for having unreported fecal incontinence in women with urinary incontinence? Which of these 4 had the highest p-values, or I should say the lowest significant p-values? Right, and diarrhea. So anyway, these 2 are really strongly related to having unreported fecal incontinence in women with urinary incontinence. And in fact, in this particular sample, about 1/3 of the women had unreported fecal incontinence, so the conditions really have a tendency, at least in this patient population, to occur together. Did everybody follow that example? Dr. Ramon, do you remember Leslie Scott? All right, here's an example for Cox regression. Dr. Miles was actually her advisor on this project, and Leslie was conducting a project where she'd have, this was like a randomized clinical trial, placebo-controlled. She wanted to know if preoperative chlorhexidine vaginal scrub in women undergoing a C-section significantly reduced the rate of post-cesarean endometritis and wound infection through 6 weeks. Most of the endometritis, I'm betting, would probably come out in the first week. Wound infection would take longer through 6 weeks. Unfortunately, while this study had a great concept, she just wasn't able to recruit a lot of patients. So the end result of her study was rats, rats, rats. We can't really do anything. But an analogous study done by Starr and her colleagues at the University of Chicago Hospitals, my old stomping grounds, this is where I was born, she actually looked at a similar situation involving povidone iodine solution. Now, she did not use a placebo. She just compared patients receiving a preoperative vaginal scrub with povidone iodine with women who received standard of care abdominal scrub. But the results of her findings are listed here. If you had severe anemia or used intrapartum internal monitors or had a history of antenatal genital urinary infections, all of these were significantly related to increased risk of endometritis. But here, this is what she was really after. This is why she did the study. Women who had the preoperative vaginal scrub with povidone iodine had less than half the risk of endometritis as women who just received the standard of care abdominal scrub. This wasn't significant by much. I mean, it just made significance by the skin of its teeth. It almost overlapped 1. But anyway, her end result was borne out that apparently this is a good thing to use in her patient population to reduce post-cesarean endometritis. So eventually it'd be nice if we could do something similar to that with Leslie's study, but we'll see. Anyway, to wrap all of this up, an understanding of statistical procedures is necessary to critically evaluate the medical literature. Statistical tests vary according to characteristics of the data and the research questions to be answered. The most common univariate statistical test for categorical data is the chi-square test. This measures the degree of association between 2 variables. The most common univariate statistical test for continuous data from 2 independent samples is the independent student's t-test. It compares the means between 2 samples. The correlation coefficient measures the strength of the association between 2 variables. Regression statistical procedures are employed when the primary aim is to develop a predictive model of a dependent variable. Models may include one independent variable, simple linear regression, or multiple independent variables, multiple linear regression, which we actually did not talk about, multiple logistic regression or Cox regression, depending on whether the dependent variable is continuous or dichotomous and whether prediction is to be evaluated over an element of time to adjust for differential length of follow-up. Now this is just a smattering of a lot of different examples and research questions and the relevant statistical tests used to answer them, but really we could spend days and weeks talking about statistics. I thought this would be a good collection of a lot of the more relevant statistical tests that are used in research with a lot of MFM examples, particularly involving the fellows. So does anyone have any questions on what I've talked about or comments?
I think you did a very nice, excellent job.
Thank you, Dr. Ramon. And I appreciate all of your participation and questions, and thank you all for coming, and I look forward to working on your projects with you.
That's great.
No, I'm excited about it.
You happy already?
Thank you, that was really good.
It was good?
I missed a tad bit of it, but I will hopefully catch up with you.
Suwan, I was using you and Gary as an example. Are these Wednesday morning lectures good, or are they full of prunes?
There's always correlation. We always need to follow prunes. So.
Right, thanks for the degrees of freedom too. That was very good.
We're going to keep a copy of that thing if that's okay with you, but I think we delete the first one. I think the first one, if that's okay.
Wait, the first one that you put on is an old one.
Yeah,
Keep this one. Keep this one.
Extra handout. Can I use this handout? Whose is this? Can I use it?
Oh, that's mine. Were there no extra handouts?
I'll get one.
You just could put it on the desk.
Suwan, if there aren't any extra handouts, you can just take this one and I can print off another one for me.
Sure. Let's steal that.
Yeah. Wait, let me make sure. There's sometimes I write notes on things. No, that's
You already
fine. You can keep
you already
that.
saved it here. Let's save it. Okay.
So actually, what you guys do is like you save copies of lectures.
We
Did you actually
saved
make
it.
an audio of me too talking?
He did, yeah.
Oh wow.
Yeah,
Very
you
good.
are. That's the thing on the bottom.
Oh, all right. Yeah, make sure it goes with this one.
Yeah.
Yeah.
We'll save
It
it.
was in a different position on my computer, and that's why I told Suwan to just simply pull it up